Yeah.
That I can tell you. You do not look that aesthetically like Pablo, but still it's not bad.
Oh,
Makes you like the captain.
Abhida, she was with us now. Yeah, wonderful.
Good to see you.
Let's see.
Ramesh, hello.
Ramesh.
Ramesh is there. Yeah.
Yeah, good to see you.
Where is your picture? You are.
Pablo, but still it's not bad.
Abu sir, I missed you in Turkey. You were supposed to come to Ankara, no?
Yes,
Okay.
I was in Ankara, but came Istanbul.
Okay, there was a meeting over the weekend. I was there on Saturday and then came back. I thought you were no.
I went only for Sunday.
Oh, I see. That's how I missed you. I left on Saturday.
Guys are traveling like crazy. Me with the Trump administration, I feel like I should not move at all. This is happening. It's a nightmare. I'm not allowed to say that, but it is. It's like,
You don't know what will happen when you return if you move.
yeah, like he stopped funding for the NIH. Just imagine this, right?
Yeah. Some people were talking about one hospital. Which hospital was it? The two sites. One is the private and one is the NHS. And the funding was cut so that nobody can travel anymore. They can't.
Yeah. They told us like, you're on your own. And you think like, wait a minute, it says in my contract I'm allowed to travel. And then they said, well, if you're willing to pay it for yourself, you can travel, right? But and I do most of the time anyway, but it has reached the point of, it is bizarre. It is bizarre to the point of the universities. I mean, Harvard is going to lose billions of dollars in funding, and because all the people that would like to do academic work rely on the infrastructure, right? So the argument is the universities take too much money out of the NIH to pay for their overheads, right? For the lab space, for the equipment. They don't use the money really for the grant project per se. And I can see the argument in some ways, you know, if you pay more than 50% of your grant money to your institution, the grant giving body may argue that's not the intention. But it's a discussion we can have over beer at some point. It's
strange. So you really feel it?
Yeah, it's unbelievable.
It is.
Harvard is in big trouble anyway, right? Because they have fused now the Brigham and the Mass General. They did that before for buying supplies and everything else and advertisement and administration. But now they're forcing the fusion of the clinical departments. That's why the chairman of Mass General, Bob Carter, who's a reasonable guy and good tumor surgeon, he left, right? He left to Utah to be VP of some healthcare system. Of course, he makes more money, but only Nino Kyoka is left, who initially did not win the chair for Harvard. He now is the super chair for all of Harvard. And he needs to cut down, you know, from 50 neurosurgeons to maybe 30, because they have 50 neurosurgeons, right? Is that crazy?
50 like 1-5 or 5-0?
56, 5-0.
5-0. It's quite a lot. They operate on each other, don't they?
Yeah.
It's good to see you, Stefan.
Hi,
Stefan, hello.
Hi, Stefan.
You're muted.
Now, can you hear me?
Oh, yeah.
Yes.
Yeah.
All good. All good. Wonderful.
And Pablo is on different.
Pablo, once is enough.
Yeah.
No, believe me, it's not.
It's like you are dividing like the Matrix movie and splitting into.
Matrix.
Pablo, what's happened to your finger? You were playing classical guitar too much.
Can I tell you the truth?
Yeah.
Yeah,
Before
do so.
we started recording, I was placing screws yesterday on someone's back.
Oh, really?
Don't do anything as a brain surgeon. Just don't.
Really.
Why
This
do
is what happened after 2 or 3 screws. I had a,
Oh,
but
yeah.
that
Like a
really
blister.
gone.
Yeah, like a blister, was
So I
it?
promise you, it's the last time I do that.
There is the message.
Yeah,
It
exactly.
means you are not
That's-
made for spine
yeah.
surgery.
I know.
Stick to the white matter and brain tumors. Yeah.
It's not much of a medicine.
Yeah.
It's a craft.
It's true.
So Imad, I think you wanted to start.
Should I go ahead?
Please.
Yeah,
Yeah, just a
2 o'clock.
few minutes. I just want to convey that bad news that you all heard about it. We lost one of our greatest member, distinguished member, Vinko Dolenc. You all know of him, a great person. He is the master of the cavernous sinus, modern time surgery. I just want to share a short story. He shared it with me when we were in South Africa on a coffee time. Interesting, I say this person is self-made neurosurgeon, never left his country per se, and got his training in Ljubljana, in the small city. He made it a big city for the world and for the cavernous science. But the story, when he was a first-year resident, he stolpered on his feet and fell with his hands on a nail. So he damaged the digit 4 and tendon were ruptured, was repaired on situ. Of course, suture on situ, infection, malunion, and he went to England to have an attachment for general surgery rotation as a young resident. The chair there, he was not happy with him, he told me. He was shouting on him all the time during the procedure. He told him, you don't fit to be a surgeon, and he kicked him out. But he realized later, he talked to him, he said, why you choose surgery? You cannot even hold a retractor on the liver. And he told him, I have injured my finger, and I showed him his finger clumped like this. He said, I am sorry, I'm going to take care of your finger. He was also a hand surgeon. So he prepared his tendon again, but again was a poor vessels. So this young resident was the paragon of cavernous sinus surgery and vascular surgery over the years with the chrome 4 digits hand in the right hand. Yes, he performed all these procedures and he wrote all these books, and he continued to be a pioneer. A message for the young people attending this webinar: you never give up, and you always try to overcome hurdles and burden that you have. That's what I want to share with you and for the audience of this webinar. So God bless his soul, and I hope his family give them the patience. He has his daughter who is a doctor as well in the same institution. And I have to commend his previous resident who became the chief eventually, Dr. Roman. He was very nice. He communicated with us. He gave us part of his CV and nice pictures. And it was a blessing to have people following Professor Dolenc. God bless him. That's what I want to conclude. The other thing I want to say for the IANA, I'm happy that the fellowship, we started with the first one in fellowship training. And one actually from Saudi Arabia went on his own course, but we arranged it with the Professor Matthias. He took him for 3 months rotation on research. And the guy, he was very happy. He received a 3 weeks intensive course on white matter dissection. And he is one of the future young candidates. So we are still looking for more young generation, especially from less privileged countries. And I appeal to Professor Qureshi, Professor Kasadi, who are from Africa. I'm sure there are people desperate to have some training, and please, we can offer them some financial support, and we have 5 centers available. So try to make propaganda for these people and to support people from all over the world. Thank you. Pablo?
Vlad, you wanted to say something?
Yeah, I may remember Vinko as well. You know, I first met him in 1982 during the IANS course in Ljubljana. And at the time, the part of the course was also football match between the teachers and the trainees. In Ljubljana, they didn't have a flat field. It was really like a hill, uphill, downhill. And Vinko, playing for the teachers, decided that they will play downhill. So we as trainees never could have won. It was impossible because we played uphill. And the message is, same as Imad gave some message, choose the field with the advantage. And it's general which you can use anywhere, whether be it football or whether be it neurosurgery.
Thank you.
Thank you, Vlad. Thank you, Imad.
Thanks.
And I think we can start, if you agree, Vladimir, with the
Yes.
first session.
Sure. Me or you?
So can you introduce our first speaker, Abida?
Abida, well, let me introduce Abida, but I don't need that. She does need any introduction because we all know that she has spent considerable time with Atul Goel, that their lectures were quite frequently interchangeable, and that we have learned a lot. But what's more there in Abida is her white matter dissections, which are extraordinary, unique, and always beautiful. And I believe that now Abida will join both white matter dissection and tumor surgery. Abida.
Thank you. Thank you, Professor Banes. Thank you, Pablo. Thank you, Dr. Kanan. And it is indeed a pleasure to be a part of IANA. And I will start my screen now. And it was really nice to hear those stories about Professor Dolenc. Can you see my screen?
Yes, everything's all right.
Okay. So today we are going to see how understanding white fiber anatomy helps to plan surgery for gliomas. So we all know that the state of glioma surgery has changed. It has changed with these advances in chemotherapy and radiotherapy for high-grade gliomas, and it has changed for low-grade gliomas in the form of supratotal resection or radical resection by using mapping techniques and understanding the function of the brain and how to preserve it, understanding plasticity. So all in all, we've gone a long way from just taking a biopsy for low-grade gliomas to performing a radical resection. So there are a lot of adjuncts that have come into play. We have tractography, there are functional MRIs, there are transcranial MRI stimulations possible. We have this tool that is the intraop ultrasound, then people have intraoperative MRI. But what forms the basis of all this? Just like when you sing, you're going to start with do, re, mi. When you plan for a glioma surgery, you have to understand subcortical anatomy. You have to understand the highways of the brain, and you have to know how to navigate them. So basically, the human neural network consists of nodes or cortical areas connected by a series of edges or links, which are the subcortical network. And this whole system gives rise to a fascinating grid of motor, sensory, autonomic, and emotional function. Everything is hodotopic. So both the cortex and the subcortical anatomy is important. Based on all this understanding, the new game is connectomics. And people have defined these major networks in the brain. The concept is that similar areas, eloquent cortical areas and the subcortical network connected by one function will fire together. And it is important to preserve this network when you're performing the surgery. So just to give you an example of the language pathway, which is there are two major language pathways, the semantic and the dorsal pathway. So the semantic pathway is the ventral pathway, whose main fiber bundle is this one, the IFOF, which runs from frontal to temporal. And the substrates are the superior and middle temporal gyrus and the dorsolateral prefrontal cortex. The other fibers are the ILF, the uncinate, and the middle long-terminal fasciculus. The other pathway is the phonologic or dorsal pathway, whose main fiber bundle is the arcuate fasciculus, supported by this SLF3. And the substrates are the inferior and middle frontal gyrus and the superior temporal gyrus. So this is how connectomics works. You have to understand the pathways, and then you have to perform the surgery. So this is a representative image showing the damage to the subcortical network, the deficits that it can cause. And this is a table showing the same. As you know, I'm extremely interested in white fiber dissection. And based on my understanding, I classified these white fibers into 5 groups. So earlier we looked at white fibers as association fibers, commissural fibers, and projection fibers. But that gives you a functional understanding, or that just gives you the connections of the fiber tracks. If you look at them in an anatomical perspective, that is what is required for surgery. So this is how I have understood them anatomically. So the first group is the superficial group, or this yellow circle here, that is the short arcuate fibers. The second group is here, the middle group, or the long association fibers. The third one is the deep group, or the association fibers in relation to the ventricle. The one in the middle here, these red fibers, the central group, are all the commissural fibers, and generally they remain confined to the center of the brain. Of course, there are some radiations of the corpus callosum will go and meet the vertical fibers medially, and the anterior commissure crosses from below the brain and goes laterally to the temporal aspect of the hemisphere. The blue one here is the projection fibers, consisting of the internal capsule and the thalamic radiations. So if you look at this image, fibers that are long association fibers that are lateral to this vertical group are lateral to it, and they will not be found medially. Similarly, long association fibers that are medial to this group will be medial. So that classifies your white fibers into fibers that come in the lateral approach and fibers that will come via the medial approach. And that forms the basis of white fiber dissection. Going secondly to gliomas. This is an image from Professor Yasser Gill's textbook where he depicts how the glioma grows. He said that they all grow towards the ventricle. They followed vascular patterns. They followed myelination patterns. We've gone beyond and come to this. Where does the glioma actually originate? So if you understand neural stem cells, the neural stem cells are multipotent and self-renewing, and they've been isolated from the subventricular zone, the lining of the lateral ventricle, the dentate gyrus, and the subcortical white matter. So we postulate that these gliomas arise from white matter. They arise from a named white matter fiber, and they spread along this fiber, displacing the other white fibers as they go along. So based on this, we have written several papers based on the radiology, based on how we perform surgery, and I will show you now how we do that. So if you look at these radiological extensions of gliomas, so we've divided gliomas into two types: short localized group of gliomas and diffuse group of gliomas. So this is an anatomical classification. So the localized group of gliomas arise from the short arcuate fibers. They remain confined to the gyrus which they originate from. If they go to a neighboring gyrus, they will spread by this short arcuate connection between the two gyri. The diffuse ones are the ones that involve the long association fibers, as you see in this image, going across the cingulum. This is the MRI image depicting the same, going across this connection of the cingulum to the cortex. And the second one are the ones that involve the commissural fibers, and they tend to be bilateral. So we've studied a lot of gliomas radiologically, and this is our concept. This is a 7 Tesla MRI image of short association fibers, and you can see how innumerable they are and how much we have not explored these short association fibers. They are responsible for innumerable connections. They are responsible for plasticity, and we are just trying to decipher their anatomy. So this is a recent publication where we've divided short arcuate fibers into intergyral fibers and intragyral fibers. So if you see this, there are transverse connections within a gyrus between the short association fibers. There are U connections within the gyrus. Then there are connections that connect one gyrus to the other gyrus. And then there are short arcuate connections which go all the way and connect here to the long association fibers. So all these fibers are important and have to be preserved while performing surgery. So now let's go to the surgical part. So if you look at this tumor, this is a glioma that is arising from the supplementary motor area. As you can see the anatomical location here. So it is arising from the short association fibers in this area. The motor strip is pushed behind, and this is the surgery. I think you must have seen this video before, but I'm showing it again. So we used to use monitoring before. This is identifying the motor strip. The concept is that these fibers arise from the short arcuate fibers around in the gyrus, and they are surgically confined. Histologically, they may be diffuse, they may spread from one place to the other, but surgically you can develop a plane of dissection while operating on these tumors, and this plane is beautifully defined, and you can remove the tumor in a whole en masse fashion, as you can see in this video. It's almost coming out like a meningioma. We have identified this by sonography also. I will show you the few images later on. So this is, for lack of time, I'm just going fast. This prevents any vascular injury because all the vessels, you're not coagulating within. You can separate the vessels from the dome of the tumor and actually remove the tumor in an en masse fashion. So this is the post-operative scan. You can see the radical resection. You can see that the motor evoked potentials have been preserved and the patient did well. Now coming to this tumor, you can see that is going all the way to the corpus callosum. It is involving the cingulum. It is involving the supplementary motor area. We performed a radical resection on this tumor using this en masse technique, but this patient developed an SMA syndrome. So she became transiently weak on the opposite side, which recovered within a matter of months. But this patient took a long time to recover because we went all the way down to the corpus callosum. Based on our experience with supplementary motor area tumors, we analyzed the white fiber anatomy and connect with supplementary motor area. And we realized two things. One is, if you do not cause injury to the cingulum, if you try to stay above the cingulum, preserving the cingulum, you will avoid getting an SMA syndrome. And also the frontal echelon tract, which you see running here, lies at the same level horizontally as the cingulum. So if you're remaining above the cingulum, you tend to preserve the frontal echelon tract. This is a tumor I did last week in the classical supplementary motor area. Here you can see the preoperative images removed in an en masse fashion. Here you can see here I've just gone to the level of the cingulum, and this patient did absolutely well, no SMA syndrome. So these are some recent concepts. This is a tumor that is arising in the middle frontal gyrus. You identify the short arcuate fiber in the gyrus in which it is arising from and go on to perform an en masse resection, and you can see the tumor and the post-operative MRI. So you have to understand on the lateral aspect of the brain, there are some fiber bundles that will come. That is the arcuate fasciculus, the SLF2 and the SLF3, or as I like to call them, the lateral part of the SLF. In the connecting the frontal and the temporal, you will have the IFOF, and more anteriorly, you'll have the uncinate fasciculus. So if you're coming in the lateral aspect, you have to understand the anatomy of these white fibers. Now, this is a tumor in the pars opercularis. So the classical Broca's area, where if you cause a stimulation, you will have speech arrest. So the ventral premotor area. But this patient was absolutely refusing to perform the surgery awake. He was not educated and he was worried. So we could not do him awake. But based on our understanding and our concepts, we went ahead and performed an en masse resection, as you can see in this video. You can see, you can easily distinguish by the color, by the consistency between the tumor and the underlying white matter. Another important thing is when you're doing white fiber dissection, you start gauging the depth of the long association fibers. And it helps you a lot during surgery because you know at this depth, if you go, you will cause an injury. So this is the en masse resection of this tumor. And you can see the patient in the post-operative period. Some bits are there, but he's speaking. It's her. And this is the radical resection of the tumor, fibers that are preserved. Coming to the insula and the opercular region. So here you can see the sonography and you can see the whole pars opercularis is involved by the tumor. You can see that the color is different. You can, once you operate, you see the consistency is different. So this is the tumor. Again, I have performed an en masse resection. Here you can see the post-operative resection cavity. This is the specimen, and this is the post-operative sonography. This patient did well, no problem, without any deficits. This is again another high-grade tumor. Now, high-grade gliomas also follow a similar pattern. They are surgically confined, but they are high-grade by virtue of their biology. And you can go ahead and perform a radical resection. Of course, you might have to enter the tumor because of its bulk, and sometimes it's more friable than low-grade tumors, but you can form a plane of dissection and go around the tumor. Coming to the insula, understanding the anatomy of the white fibers is most important because you cannot transgress certain boundaries and you cannot cause any injury to the middle cerebral artery branches. So this is the region of the Lyman insulae where you have the uncinate fasciculus and the IFOF. This will be your limit of resection medially. Here you have the external capsule and then the internal capsule. You should not be entering in this area, otherwise you will get a deficit. This is the arcuate fasciculus and this is the SLF2 and the SLF3. So when you come on the lateral aspect, these are the fiber bundles that come into play. And this is the anatomy you have to remember when you're operating. So just to show you an image of all the fibers, the arcuate fasciculus lifted. This is the IFOF going back, lifted, and then this is the optic radiations. This is the internal capsule. Here you have the SLF. These are fibers of the corona radiata. And here the whole internal capsule has been dissected out, showing the anterior limb, the genu, the posterior limb, and the sub and retrolentiform part. So this is important when you're doing insular gliomas. And here you can see the preoperative image of this insular tumor. And just using this anatomical knowledge without any mapping and monitoring, I have used a Transilvian approach and operated this patient. And you can see the postoperative MRI. Again, another insular tumor recently operated. And here you can see the resection cavity. This is an immediate postoperative MRI. On the left side, we sometimes do awake, but a lot of our patients are not very cooperative. And then we use this anatomical knowledge and go ahead and remove the tumor. This is a tumor in the posterior insula where we used tractography and navigation to get to the tumor, opened the Sylvian fissure, and went ahead and did a resection. And the patient did well following the surgery. Coming to the medial aspect. So we've seen the fiber bundles on the lateral aspect and how they are important. The medial aspect is the limbic system. The most important one here is the cingulum, as it arises here in the subcallosal region and goes all the way back to end in the radiation of the cingulum. And this is the whole Pappus circuit that is dissected out, the hippocampus, the fimbria, fornix, mammillary body, columns of fornix, anterior nucleus of thalamus, anterior thalamic radiations coming to the cingulum, ending back here. And these are the cingulate connections to the cortex. These are thalamic radiations. When you dissect from medially, this is the last fibers that will come into play. This is the Pappus circuit that we have dissected out. Now, how does this relate to surgery? So when you're operating on mesial temporal structures or mesial temporal lesions, you have to understand that the IFOF and the optic radiations lie in the roof in the anterior aspect of the horn and lie in the posterior, in the lateral part of the lateral wall of the horn in the posterior aspect. So it is safe to enter from this point. We use this for our epilepsy surgery. This was described by Professor Goel. And we are also using it for medial temporal tumors, as I will show you now. So this was the paper. Now you see this tumor. This is a tumor involving the limbic area. So the amygdala is involved, the uncus is involved, and the hippocampus is involved. The approach is transcortical through the middle frontal gyrus in the anterior aspect of the temporal horn, where there are no fiber bundles that will come in your way. And this is the radical resection. Again, another tumor in the hippocampus and parahippocampal gyrus. So this is the anatomy. This is where the tumor is lying. Again, we have operated it using a transcortical approach, but performed, of course, a supraradical resection and removed the tumor, and the patient did well. Now, this is not a tumor of the corpus callosum. This is a tumor of the cingulum. It is not bilateral. If you see, it is unilateral. That distinguishes it from a commissural fiber tumor. So this is the tractography images operated with neuronavigation and in an interhemispheric approach, and you can see the resection and the tumor has been removed. So these are all limbic and paralimbic tumors. Lastly, coming to deep-seated tumors, white fiber anatomy, if you look on the base of the brain, there are hardly any fiber bundles that come into play. And if you have a tumor that is lying in this location, of course, you can come transcallosal, contralateral transcallosal. This is a big tumor, but sometimes the tumors are quite small. They lie here in the region of the caudate head. So there is a straight trajectory that you can come from here without causing any damage to any fibers. The only one that will come into play may be the forceps minor at the region of the frontal horn, but this is the trajectory. This is a very short and quick trajectory to reach the tumor. The commissural system of the corpus callosum is a magnificent structure. It connects both the hemispheres to each other. We've called these the dorsal callosal radiations, the anterior callosal radiations of the forceps minor, the posterior callosal radiations of the forceps major, and the ventral callosal radiations. So the anterior ventral callosal radiations and the posterior ventral callosal radiations, and they envelope the whole ventricle. The corpus callosum envelopes the whole ventricle in its radiations. And when you perform a callosotomy, we have changed our strategy, and we now use a transverse callosotomy instead of a vertical one, so that you splay the fibers instead of disrupting this. These are safe areas to perform a callosotomy. This circle says a no for entering the corpus callosum. And if you know these radiations, you will understand the spread of the tumors. So this is not a bizarre tumor. It is involving both the dorsal and the ventral callosal radiations. And you can come by an interhemispheric approach and remove the tumor radically. This is again a tumor of the forceps minor going bilaterally. So I have come from one side and removed the tumor as radically as possible from both the sides. And lastly, the brainstem. This is still an uncharted territory for how these gliomas come, but we have done a lot of fiber dissection on this structure also, and it is very, very nice and interesting. We've divided them into these zones, but that is another lecture. So I thank you very much for your time. For those who are interested, can read our book on the subject. Thank you.
Thank you, Abhijit. It was excellent as always. A nice connection of white fibers and the tumors. Sometimes surprising. Any remarks or someone would like to comment on the Abhijit's lecture?
Absolutely fantastic. I think your strategies very much align with how I see resection strategies evolving along natural pathways. I just want to know a little bit about your clinical workflow and sort of pre and post-operative cognitive testing, because we are always being challenged by a lot of our colleagues, yeah, you can take out anything on imaging, it looks perfect, but how is the patient doing? So maybe you can comment briefly how you do this in your institutions.
So we do neuropsychological assessments on not all, but a few patients. As you know, I cater to a poor population, a little uneducated population. So they aren't, even educated to maybe 6 standard or 10 standard. So for those, we have difficulty assessing cognition. For example, I had a tumor in the left temporoparietal occipital junction. So I operated this patient. I didn't have a pre-op cognitive test. But then post-operative, I wanted to assess him. And I tried his reading. I asked him, can you read? He says, no. So he didn't know how to read. I asked him, can you write? He said, no. So the assessment is a little difficult because they don't know how to do it. So we face a little challenge, but we do. So we don't go over a certain limit, because I don't think that even if the mapping says there is no function, probably we are not able to map it, because the brain is not something that is, will not have function. Even a small part of the brain will have function. So maybe there are things we don't know. And we don't have a lot of neuropsych assessments, but in the ones that we are doing in our patients, they're fine. They're not coming back to their life. They're not being restricted at home.
Thanks. Thank you, Abhi. I must say, Vladimir, that we have a chat box, and we have 120 people right now following the webinar. So if there is any question that any of you want to share with us, we will have a discussion at the end of the both sessions.
Okay.
So
Abhijit, Pablo?
Yes. Yes, the thing is that I'd like to move on, because our next speaker has an important issue to be done after his talk. And I'd like to introduce, and we are very happy and proud to have Prof. Joachim Ortel with us. He's a very well-known neurosurgeon and fantastic educator. He's really good at, I'd like to say, minimally invasive approaches, but most important thing is that his concept of endoscopic surgery, not only in skull base, but also spine, pediatric patients. And today I think he is going to talk us about how we can optimize the use of the endoscope, if I understood, and stereotactic technologies to biopsy ventricular and paraventricular tumors. Thank you, Joachim, for being with us.
Yeah, thank you so much. Let me see. Okay. Do you see my screen? Perfect.
Yeah.
Yeah, it's a very particular small indication I will cover today. It's the combination of using an endoscope and in stereotactic guidance in biopsies, mainly in paraventricular and in interventricular tumors. And it's a pleasure for me to be part of this. And unfortunately, I have to leave at least for 30, 45 minutes, 10 minutes right after my lecture. But, if you have any questions, just send me an email. It's no problem. There's disclosure. Nothing is related to this presentation. And this is where I'm from. I will go through this very fast. It's right the center of Europe. And this is our university. So when we talk about endoscopic treatment in interventricular and paraventricular lesions, we always think about association of tumor and CSF circulation problems. So this is a typical application of a full shear endoscopic technique. So we restore the CSF circulation, and then we do a resection or biopsy of the tumor. And basically any lesion which is very close or within the ventricular system is a potential candidate for this endoscopic interventricular approach. You see here two examples. One is a subepineumoma in the third ventricle, and the other one is a thalamic glioma. And both are basically suitable for an endoscopic approach, but it depends, of course, of the indication, whether it makes sense to use the endoscope or not. So what are the considerations for resection versus biopsy? There's a little bit of flow in these general thumb rules, because we have used now the endoscopic ultrasonic aspirator and the laser more frequently recently. So I think the size of the lesion, if it's an avascular lesion, can be much bigger than we thought about 10 years ago. But as a thumb rule, it should not be too large, because otherwise it's too time consuming. For resection, for biopsy, size doesn't matter. The location of the lesion is important, because we want to address the lesion without harming any eloquent structures. And the vascularization is a big topic, because if you have a highly vascularized lesion, probably it's very, very difficult to do a tumor resection. Biopsy would be possible, but tumor resection is an issue. And of course, the size of the ventricles matters. It's much easier to maneuver the endoscope if you have a hydrocephalus-associated tumor than in a slit valve ventricle system. So what do we do when we have small ventricles and inter- and paraventricular lesions? Well, the endoscopic tumor resection, a shear endoscopic tumor resection, might not be feasible, because it's difficult to maneuver, to use the working space. And the freehand biopsy of lesions is limited and restricted with the range of motion of the endoscope. So we did a small series in these selected cases where we combined the flameless stereotactic biopsy and mainly with a Sedan probe with under endoscopic guidance, so under endoscopic view. What are the theoretical advantages? Well, the accuracy is almost like in a stereotactic guided surgery, but you have direct visualization of the biopsy area. So you actually can rule out any postoperative hemorrhage, and you might even have a better understanding of the sample size and of the if the sample is representative for the final histology. So when we have done this now I think we have done this for close to 14, 13 years, but it's a rare indication. So we use it in small ventricles. We use it with navigation, and in our hands we use a Medtronic system, which is probably the same with any other endoscopic system. You just have to have the opportunity to apply your endoscopic equipment in the navigation guidance. And the idea is that you have a real-time control of the position of the endoscope and the biopsy site, so you can see if you do the biopsy whether you have a hemorrhage or not. And we preserve this technique for small paraventricular lesions mainly, because then it might be more difficult to do a shear endoscopic approach without stereotactic guidance. And we try to use a Sedan probe. If this is not possible, we have to switch for the grasping forceps, but the grasping forceps, the risk of hemorrhage is a little bit higher than with the Sedan probe, in my opinion. The big advantage is that we have the intraoperative control. We see whether we are right at the lesion site, and we have the control that we don't have immediate hemorrhage after sampling the tissue. However, what are the disadvantages with this technique? Bimanual surgical technique is not feasible. So if you have a hemorrhage, you have to open up, but you see it right away. It might be difficult to really deal a major hemorrhage with a shear endoscopic technique. And the other option is we always have with these tumors, many of these are gliomas and metastases, lymphomas. We frequently have with these gliomas bleeding when we do the biopsy, and even minimal bleeding will cause a blurred vision. So what is the equipment? We actually do most of these a rigid endoscope. There are some we did with a inspection with a flexible, but this is not the topic of this talk. We do a rigid endoscope, and then we use working optics, and we use mainly the sedan probe for the biopsy sample, and irrigation bipolar for hemostasis. And this is our setup. Most of these we have done with a GARP endoscope, but any other is possible as long as the sedan probe fits the worksheet. And then the sedan probe is used for navigation, so as the tool to track it in the navigation system. And then we plan, like in any other stereotactic frameless biopsy case, we plan our trajectory, but we go through the ventricular system. So exactly the opposite what you do when you do stereotactic guided biopsy. You try to avoid the ventricular systems because you are afraid of the perforation of the ependema. Here, in this case, we actually enter the ventricular system and go from the ventricular system to the lesion site. What does this look like? This is a case here. You see, this is a case very suspicious for thalamic glioma. And this is the intraoperative C. It actually turned out to be a left thalamic glioblastoma. And this is now the sedan probe. We see that the ependema itself looks similar, looks normal. So you have the suspicion that the tumor is there because you have a bulging, but basically the ependema is normal. You cannot really identify the tumor. And then we use the stereotactic guidance and use the sedan probe and bring in the sedan probe and do the sampling. And the big advantage now is that on one hand, we see whether we have a representative sample, and the other advantage is that we see whether we have any bleeding at the biopsy site or not. This can be done about 4 or 5 samples. And now we retract it. You see that there's quite some nice tissue inside the sedan probe. We take it out. You see, as always in these tumors, you have some moderate bleeding, but you control the bleeding with either with a bipolar or with irrigation itself. And you just wait and clean it, and you're sure that because you have a representative sample and you have no postoperative hemorrhage. Another example here. Also selection of the tumor. The ependema here looks a little bit reddish, but basically it's still ependema. And we do the sampling, a little bit hemorrhage, and then at the end we are sure that we don't have any hemorrhage at the biopsy site. This lesion was a lymphoma in the right thalamic region. And another case here, it's also a right frontal lesion, looks like also a glioma. This is the intraoperative situation. Here we did the opening of the ependema with a laser probe, and now we introduce the biopsy sample. And in this case, actually, we did the sedan probe. We did not get a good sample because it was more or less a cystic lesion. We actually did sample with a biopsy probe here, with a biopsy forceps, which is more aggressive. And then at the end, we're sure that we have enough sample. And this is the post-operative CAT scan, and it turned out to be necrotic CSF tissue without malignant process. And actually, this patient was followed, and on the next follow-up, the lesion did not grow and did not change. So it's probably a post-inflammatory scar. Okay, I will skip one more sample. This is a pediatric patient. There was a combination with an ETV case, and now we'll go for the sampling. And here, this is an easier case because here you have already the impression that this case is you can identify the tumor under view. So I agree with you. In this case, probably the navigation guided frameless navigation guidance is not required as in the other cases. So this turned out to be a polycystic astrocytoma. Okay. I will skip these cases and go for my conclusion. So we have done 11 years of experience, and we have done exactly 20 patients. And in the adult population, the youngest one was 18, the oldest one was 82. If we count this pediatric case, then we had one pediatric case, but I did not count it in this series because it was not an ideal case, because you see, you could identify the tissue under direct endoscopic view. All these were navigated with a frameless stereotactic guidance, and for paraventricular lesions, shear endoscopic technique, histology was obtained in all biopsies, and we could directly control hemostasis in all cases. And since this helps to avoid postoperative bleeding, there was no postoperative bleeding in this series. I think the first 12 or so were published in World Neurosurgery in 2019. And to conclude, endoscopic biopsy with a navigated serum probe, it's a possible technique in selected cases when it's difficult because it's right paraventricular lesion in small ventricles, and you think that direct endoscopic view is not suitable because you might not be able to identify the lesion. The endoscopic approach enables direct visualization of the target area, and in contrast to the standard stereotactic biopsy, we can visually control the hemostasis after the tumor sampling. And I thank you. And if you're interested, these are our workshops and courses this year. Thank you for listening.
Joachim, it was great. And so are there some remarks or questions on the technique, which is really unique?
I think I must say, Vladimir, sorry, that our experience with the classic neuroendoscopic biopsies with the forceps, the rate of positive histology was not so high. So I do believe that using the needle with the stereotactic probe is quite helpful. I've tried it myself in a few cases, but the difference is that we were using two different trajectories. One for the endoscope to have an overview or to perform septostomy or third ventriculostomy. And then we planned the classic standard stereotactic needle biopsy. That's the only difference, but I'm very impressed with the results. All of the patients had positive histology, which is a lot.
Pablo, this is one problem, that when you do the shear endoscopic biopsy, you tend to not to do sample deep enough, and then I think we had the same problem. This is very classic, that you do sampling and then at the end histology is not representative. Yeah, thank you so much. I have to go. I will join you later again. Okay, thank you. Bye.
Bye.
Pablo, we are using also frozen section intraoperatively also for biopsies. You can send the pathology, a frozen section. Then if they say, yes, this is a tumor, you can finish. I think
you know what happens when we do that? Usually, as they know that we are going to send very small samples, they tell us that it's better to keep all of them for the definitive pathological study. This is the answer, I promise you.
One more thing for the Sedan needle he is using, which is very important because it has a side window. If you rotate that Sedan needle in situ, you are taking samples around the clock, and it gives you more representation than a single needle give you one spot. So the Sedan needle with the side fenester, and rotating it gives you several samples unnoticed, which is very helpful. He reminded me about my first case of endoscopy more than 25 years ago, published. It was using the uroscope, pediatric uroscope, as an endoscope, we didn't have this pediatric endoscope, but we borrow it from the uroscope, and we use the YAG laser fiber developed in Graz, and the bleeding you get in most of the cases is not a frank bleeding, and it's enough to do a good irrigation on the spot that it will ameliorate that bleeders in most of these biopsies. Thank you.
Giovanni.
Yes, I support the use of the Sedan needle. We have a lot of experience with doing biopsy, stereotactic biopsy without the endoscope. And what we come out is that with the forceps, you destroy the tissue. The pathologists have a destroyed tissue. You cannot do the genetics. With the Sedan needle, you can make round samples, and this is much better. So compliments for the presentation with the endoscope. With the endoscope is something that is adding a lot to the pure stereotactic system.
Thank you.
Brief comment. So I'm not sure whether everybody has the Sedan needle available outside Europe. In the United States, a similar needle is called the Nashold needle, which is a core biopsy, 10 millimeters side opening needle for stereotactic fixed frames. And I want to encourage people to read up on previous papers by Christoph Ostertag's group in Europe. Christoph Ostertag and Freiburg published the largest series of fixed frame stereotactic biopsies of deep-seated lesions, 5,500 cases with a diagnostic specificity of about 90+%. The reason why I still advocate a conventional biopsy over an endoscopic biopsy is that the access corridor is much smaller. The biopsy can be taken through parenchymal tissue, and if there is a small bleed, it will self-tamponate and never go into the ventricle, because I see some of the bleeding as a risk for aqueductal blockage, for example. So you need to pick your battlefield and say what case is suitable for an endoscopic approach, maybe followed by a resection during the case. And I would very much advocate for what Joachim is doing. But if you only want to take a biopsy in a non-resectable lesion, one should still think about doing a fixed biopsy with that Nashold needle or with an MHT forceps system. So there's a system out there that allows you to place a guide tube of 1.5 millimeter diameter into the target area of the tumor. Through the guide tube, you do a 1.2 millimeter biopsy forceps, and you take 10 millimeter steps of bites from normal tissue into the target area. You can send every other biopsy bite to fresh frozen, and you preserve the permanent in between. So you get a street of biopsies from normal tissue into target area, and you can use that for molecular studies. Really interesting technique published by Chris Ostertag's group in Freiburg. And I think it's worthwhile considering that for your cases if you're interested in it.
Thanks, Ek. So any other comment?
Well, the only comment I would make is what Ek just mentioned about choosing your battle. It's always a delicate balance between going transventricularly versus transcortically and transparenchymally. You have a terminating effect of the brain parenchyma when you have a lesion, when you attempt it with an stereotactic biopsy needle. And so obviously, when you look at Joachim's number of patients, it's a very selective cases. So you got to be very selective with the cases you choose. In 10 years' time, you need to operate about 20 cases. That means how selective he is. So I think it's important to know that you can't biopsy every paraventricular lesion with endoscope, because obviously if you get a bleed, then you will have other issues.
True. So Vlad, should we continue?
Go ahead.
So
All right, the next lecture, Matthias is not with us, I guess.
we should have Matthias, but he feels sick. So I can cover the next.
So Pablo, it's MX surgery, how I do it. All right?
That's it.
So please, go ahead.
And I didn't prepare this two tip But do let me know if you can see, because my connection is very poor right now. That's okay, but
Yes,
Right.
we can see.
It's all right.
okay. So this is a presentation I prepared in the past. This is how we do it indeed, because it's probably the most multidisciplinary surgery that we take care of. We need psychologists, neuroanesthesiologists. We use also our neurophysiologists and ourselves. So this is how we have been doing the awake craniotomies in the past 12 years. I must say that we don't have a wide experience, because we do, let's say, 10 to 15 cases per year, no more than that. We are super selective, as Ramesh already highlighted. So we choose only those patients in which we do believe that having the patient awake is going to give us a different perspective. So this is the case of speech areas, and especially patients with tumors like this one, which is located, as you can see, based on functional MRI, very, very close, or indeed in the pars opercularis. In this case, in the right side, this was a left-handed patient, which surprisingly had bilateral impressions of the speech. So you can see how the tumor is specific, in this case, is growing in pars opercularis and also invading in this 3D reconstruction. You can see the precentral gyrus. So what we call here in number 2, this is the ventral premotor area, which is very important in terms of speech. So this patient was completely intact, neurologically intact, and this is most likely a low grade. So this is the perfect case in our hands for an awake surgery. So this is how we decide, which is step 0, how we start planning the surgery. And then once we have decided that we want to do this under awake conditions, we test the patient, we explain the patient, and the results of the training is gonna give us the clue if we can do it or not. So we do tests 24 to 48 hours before surgery, or even in those cases in which the patient is not doing well, is symptomatic in terms of speech. We use dexamethasone for 2-3 days at higher doses, and then we reassess to check if the results are getting better. So we do picture naming, text reading, sentence completion, text writing, spelling, auditory naming, syntaxes, whatever we do believe that's going to be important in a selective specific case. So step 1, once we are in the OR, we use the sleep-awake sleep technique, and then we use the laryngeal mask for the beginning of the surgery and planning the positioning and the skin incision and craniotomy. So stage 1 indeed is deep sedation. We use this deep sedation, which means a bispectral index at least of 40-50 or even less, and we have analgesia and local anesthesia at that time. So we start with scalp blocking. Once the patient is anesthetized with the laryngeal mask, we do a complete scalp block. We then use the lanes and also monitoring, because we want to have a backup just in case the patient is not affording this. We use intraoperative monitoring. We use MEPs, transcranial, and even subdural electrodes, as you will see. And then in this moment, we allow our neurophysiologists to play as much as they want. So it's very important to have them, because in case we cannot do this under awake conditions, we want to go to plan B, which is to completely sleep the patient and go for a classic intraoperative neuromonitored surgery. So here we use the scalp block. And then most important thing, the patient must be super comfortable, and the anesthesiologist should be also very, very comfortable to have direct access to the airway. So that's why I like this kind of semi-sitting position, and the patient is going to be facing directly to the anesthesiology team, and he's going to be very comfortable looking at the screen in case we need that. So this is the kind of setup, OR setup we use, and it's very important, as we highlighted, that the anesthesiologists and neurophysiologists and psychologists have direct access to the patient, as you can see. Then we start preparing the skin. We prepare our incision. We clean with iodine solution. We, despite the fact that we have done a scalp block, we use some local anesthesia on the skin, and then we drape the patient in this way, so as the patient has direct and comfortable view of the situation. Then we start with the incision. We try to avoid the monopolar in every surgery, but especially in this one. Here, in case we want to deal with the temporalis muscle, usually as we need the patient to be speaking fluently without pain, what we do is we open the temporalis muscle like a T, so we don't completely de-insert it, and we leave a small remnant for post-surgery suture. We do a couple of bar holes, and at this point, the anesthesiologists, they do know, they're looking at the screen, or we are discussing with them that we should start thinking about going to the stage 2, which is waking the patient up at the point of the craniotomy. So once the dura is open, we can have the patient with us. So at this point, we stop deep sedation and we go to stage 2 in case the patient has some pain in the temporalis muscle. We use the local anesthesia, and we also use local anesthesia on the dura, as you can see in this way. We don't use bipolar, so in case we have, because it's sometimes painful, so in case we have small bleedings in the dura, we use the mosquito, and keeping the mosquito for a couple of minutes, it's enough to stop that bleeding. Then we continue opening the dura, and at this moment, the patient starts waking up, so you can see without bipolar, we can have a good hemostatic control. And we prepare ourselves again to have MEPs, so end-to-end wave inversion, and also direct cortical stimulation. You can see how good it is to work with the best team in Alicante, at least. They are so good that the patient is waking up like at home with no pain, no problems. Now what we do is we try to interpret what we see through the arachnoid and through the vessels and correlate the numbers that we decided we wanted to map. And this drawing has been done before surgery. So we want to map these points because this is the circumferential environment of the tumor. So we want to see if these points are, in terms of functional results, are eloquent or not. So once we have identified where the tumor is, we start checking and we start measuring the threshold from 2 milliamps to 6 milliamps, and we do this tapping test. We can use monopolar or bipolar. Usually we use bipolar, but in this case we were using high frequency monopolar, and we checked that in the post-central gyrus, the lateral third, we have motor response. And we checked that in the anterior limb of the pars opercularis, we had a speech rest. So these were 2 areas in which we cannot go in. And this is tumor. By definition, looking at the MRI, point number 2 is functional in terms of the speech, and it's also tumor in terms of imaging. So it's a part that we know that we are not going to be able to remove beforehand, even before we start the resection. Then we want to check how the tumor responds, and we found no response there, luckily, in the pre-central gyrus, but we did in the post-central. So this is a kind of trollard vein through the central sulcus, and this is the tumor in the pre-central gyrus and the tumor in the pars opercularis. So our anatomical and our functional map is done. So now we start with the patient under awake conditions to do the resection of the main part of the tumor where we didn't find any response, which is the most lateral aspect of the pre-central gyrus. So this is the pia. We are opening the arachnoid. So we will start through the center of the gyrus and expanding the resection to the sulci. So we want to keep in middle of the tumor and then to expand the resection and leave the most eloquent areas for the end of the surgery. So now we are taking some samples and we will go directly deep into the tumor, and we want to test how far we can go anteriorly towards the pars opercularis where we found response in the cortex. So the patient is very energetic in this first part of the surgery. So that's why we want to go to the speech. And then once we reach this precentral sulcus area, we go deeper and deeper, and we want to map the arcuate in yellow in this tractography. The patient is doing fine, so that's why we are having open conversation and his picture naming. Now going downwards to the sylvian fissure and deep. So we want to keep that area, which is the corticospinal tract, to the end, because we can check it with the patient under sleep conditions. The patient is getting tired, and at this point, we found some parafascia. So that's why we stopped the resection in this area, and we moved a little bit superior. So we left this area here. We were suspecting that the arcuate fascicle was closed, and the patient was too tired. So in this case, if the patient can afford to keep awake, we keep going. Otherwise, we can go to mild sedation and go for the corticospinal tract. So this is the area in which we suspected that the arcuate was located, and then we moved superiorly to the middle aspect of the precentral gyrus. Here we can test motor, cortical and subcortical with the patient under sleep conditions. So that's why we want to test the speech before we go too deep. Now the patient is sleeping, he's completely relaxed, and we can check with the subcortical stimulation how close we are getting to the corticospinal tract. So it's all about strategy, all about having plan A, plan B, plan C, and now we are trying to extend the resection to the most medial part of the exposed precentral gyrus, where we didn't find motor response, but we did in the depth. So right here, 3 to 5 milliamps close to the corticospinal tract, we decided to stop the resection. So this is the pre-op image. This is the post-op image. We know that there is tumor here. We know that there is tumor probably at the level of the arcuate, and we know that we could have some tumor in the postcentral. But these are the areas which were functionally eloquent. So now we start the dural closure. The patient is completely slept, relaxed. We use some dural tack-up sutures, and we close the wound. This is the post-op MRI, where exactly you can see how the arcuate was deep into our resection cavity, and we can see some tumor remnant in the pars opercularis, which we are just following up. But what we cannot see in this image, and what we cannot check and we cannot control, is the ischemia. So that's why it's very important also to try to be delicate at the level of the subpial area, where we can have these long perforators coming from the MCA branches and feeding the corona radiata. Well, that's all. Thank you very much. I hope I was on time, and we can have some moments for discussion if you agree, Vlad. Giovanni.
Just a question of anaglyptic situation. Complex of your presentation. You talk about the strategy that the team has to have, but we have to take care for the people that started doing this kind of approach. They have to select the patient. It's very important the compliance and the psychological compliance of the patient. In my experience, I had one patient that they tried to jump out of the bed with the open head and with all the problems because he said that I cannot go ahead. And another situation in which an old lady was not speaking because she has the dental prosthesis. So I think that selection and the psychological head to choose the patient is very, very important, because this is a fantastic approach for brain surgery, and compliments to you and to your team.
Thank you, Giovanni. I fully agree with you. Indeed, that's why our series is not so high, because we really select very, very, very well, I would say, the patients. The problem about that is that maybe we are missing some patients that could benefit of this, but we do prefer to have the perfect patient. That's the key of the surgery, to have a perfect candidate. I always tell them that they are the most important part of the team, of the neurosurgical team. So this is, and I truly believe that. So it's very important to have a good team member with you.
Here the experience is that something like 2 hours is the tops. That after 2 hours the patients get tired and the results are not that valid. Do you have some same experience that 2 hours probably is the limit, which obviates, of course, the intra-op MR and things like that?
That I never checked that, but honestly, I'm a very slow surgeon, and these surgeries I do them very fast because I have checked that the patients get tired even less than 2 hours. I could say I could. Sometimes they can afford it, but you realize that their responses are not as good as they should be.
Yeah.
So you must be very fast when you want to check those functions that are really eloquent, and you need the patient to be fully awake. And those ones, and this is part of the strategy, to go for them at the beginning of surgery because of that, which is generally the opposite to what I do when I have the patient under sleep conditions. I leave the most functional part for the end of the surgery. I don't know if it makes sense.
Yeah, similar.
I was going to ask about this exactly. So I was surprised that you said you leave the eloquent portion for the end of the case when the patient is maybe more tired, you have more shift, you have more swelling. My strategy has always been go for the high real estate first because you have minimal anatomical distortion. So my first question was, I assume you do not use any brain relaxation in these cases. So no mannitol, no Lasix, no hyperventilation, as good a physiology as you get, right? And then the second question was, you start at the center of the gyrus and then you work towards your sulcus. When you looked at your coronal images on the flare that you showed, there was a very nice sulcus just superior to the lesion that would bring you right to the motor fibers. And I thought you would enter, essentially subpeel, go to the sulcus and then find your depth, right? So maybe you can briefly comment on this because I thought it was an interesting concept, but it's counterintuitive to what I've seen in some other cases.
Well, thank you, Ek. Maybe I didn't explain properly how I see this. When I have the patient awake, I immediately try to go from the tumor to the speech area, let's say, as fast as I can. And I leave the motor areas, cortical and subcortical, for the end. Why? Because I need the patient to be fully awake when I'm doing working around the speech area. If he or she gets tired, then I can check the motor response with the patient under sleep conditions. That's why I go to the speech, but I always leave the motor for the end. That's the first thing. And second, if this makes sense, I prefer to leave that sulcus that you saw, which indeed was the inferior frontal sulcus, for the end of the surgery, because if I go too deep in that area and I have a motor problem, the patient is gonna experience that, and that's gonna be very uncomfortable for him. Vascular or resection or damaging or edema, whatever I do on the motor area, that's gonna be a very uncomfortable situation for the patient. So that's why also I leave that for the end.
Final question. I was surprised you use local anesthesia on the dura, because a lot of us were taught, local anesthesia can induce seizures. That's the last thing you want during a case where you have a wake mapping. So have you ever had problems with the local anesthesia, or do you use blocks at the entry point of the dural nerves before they reach the actual area of surgery?
Well, during my training, I saw some of my mentors directly injecting local anesthesia on the dura, and I saw some problems about that. That's why I use topic anesthesia on a cottonoid. Just in the basal aspect of the dural exposure, I use some local anesthesia quite diluted, and I didn't experience any problem using that, honestly.
Does anyone have any experience with intra-op MR? Because once we want to go for intra-op, we put the patient under the anesthesia again. And then coming back, if there is a remnant, we never wake him up. We just go anatomically according to the MR, but it probably might be considered to wake him up again. Anyone has an experience like that?
I have not.
No.
And I'm very jealous that you have.
Don't do it. Takes time. Oh, it helps, of course.
And also, I want to ask something, Pablo. Also, you joined as fellow for operation from Professor Tula, and I'm following his strategy about these tumors. And also, he used to perform awake craniotomy, but gave up because of maybe it was difficult previously, maybe changed presently. His strategy, I also follow his strategy to remove all tumors. He believe also, I believe that there's no function inside the tumor. Also, you have cases like that without using awake craniotomy. What do you think about that? I always used to remove all tumors because I believe that there's no function inside the tumor, and
Well, now,
most of the time we don't observe any deficit.
now you want to put me on troubles with this question. I don't know, Abuser. Honestly, I do much more gliomas, obviously, under sleep conditions, and even those ones which should be quite good in terms of localization of the tumor, and the patients or the candidates are not good for awake. I do them under sleep conditions. And the feeling I have on my own series is that maybe I'm removing more tumor in those cases in which I'm not doing awake. That's true. But I don't know what could happen if those cases that I'm doing awake and I'm leaving some remnant where I find response, what would happen in terms of function. So I cannot answer with science to your question, but I know what you mean, and I could be somehow in favor of your philosophy. I don't know what you think. Ek, or Avi, Vlad.
So my thinking is that in low-grade gliomas, there is function left in the infiltrative margin. I have a difficult time when I read Dufault's papers and I see him resecting everything that doesn't stimulate, he just takes out to do these supramaximal resections of anything we can measure. And my argument has always been, I think we take away tissue that we simply can't test. Yes, there may be a long-term benefit to progression-free survival, but at the expense of quality of life because we cognitively impair the patient. So I personally have been somewhat hesitant to remove tissue that can be resected because I can't find a function. I do feel the core of most tumors, if they are relatively speaking large, say 4 or 5 centimeters, the core of a low-grade glioma is likely not functioning. If you find on mapping that they have no vascularity, they are pale, they are edematous, they are probably resectable without harm. So you could go inside out, but I follow a beta strategy to try to do as much on block resection as possible. And I stay at the flare margin to make sure that I maintain integrity of the tumor cytoarchitecture, and I just stay away from the high real estate. So it's sort of there's a subjective element, that's why I say, as you said, there's no good answer to Abuza's question that you can resect non-functioning tissue. Yes, we all do it. Is there no function at the margin of the tumor? I'm not so sure, right? So if it's low risk, and it's, I'll show that later, at the margin of a tumor where you've already disconnected the deep part, you don't need to leave the margin behind because it's disconnected. So you may take the margin out. But in a highly eloquent area, we are much more careful with how far we go, right? So that's where the art comes in from the mechanics.
Yeah, I kind of agree with what you're saying, that just because there is no function, I would be hesitant to remove it just because, we've mapped it and there's no function. And Pablo, if you see the resection that you did, if you could, I don't know, if I appreciated it that there was a difference in actual color in that whole gyrus that you removed. I mean, I could appreciate it from here. I mean, and you've removed exactly that. You've just removed that. You've just left a little bit ahead where you had some function with mapping. I'm not sure if maybe if you had removed that, whether they would lose function or not. I mean, we'll never know, but it's just a thing. You've exactly removed that. If you see your pre-op and post-operative, intraoperative, image.
You're
Right?
completely right, Avi. Yes, I did.
Yeah.
There was a small triangle of functional response just in front of that, which was different in color. But the flare image was hyper intense, as in the presenter. That's the thing. And I don't have pathology, so I don't know if that was infiltration, it was edema, or it was tumor itself. I'm just following this patient up, and he's doing quite well for the time being.
And do these patients do they have a temporary deficit or they don't?
Yes,
Like
this patient had some dysarthria, but I think he had it because of this infarct on the corona radiata, and that started happening at the end of the subcortical resection. That's when we decided to sleep the patient, and after a few weeks, he completely recovered that dysarthria.
Mm-hmm.
Could you make a brief technical comment on when to use the CUSA and when not to use the CUSA? Because I actually think in low-grade glioma, the texture of the tissue and even how it sounds in the suction and how it feels when you peel it away gives you some tactile feedback, for a lack of a better word, of where's the margin of the edematous tissue, infiltrative tumor, maybe normal, right? And we all heard, like Yajagil used to say, you can hear whether you're in the tumor, and Charlie Theo says that all the time. I don't use a CUSA at all in gliomas. I think I'm losing an element of touch, right? But if you want to be fast, as you said, in these awake surgeries, maybe you decore it in the middle and you reserve the rest of it at the margin. Just tell us briefly how you do this for people who go into.
Well, I use the CUSA always, but sometimes, and in many parts of the surgery, I'm not pressing the pedal. So I'm just using the CUSA as a normal suction device, which gives them that texture and that movements that you are highlighting. I agree with you, but in those cases, in which I want to check how far I'm getting, or I want to check this kind of feeling, which is very, very difficult, I would say. I don't have a trick for that. And then if you have something which is clearly tumor, you can just press the pedal and use the CUSA. But I have it ready for every glioma.
I like CUSA. I use it, let's say, something which I call passive mode, that you put the tip into the tumor, then you hit the pedal, and you somehow suck the tumor. And it really dissects. It's much better seen in meningiomas, but in low grades, it's exactly the same. This passive mode, not moving the tip, just letting the tissue coming to you. It's very helpful.
Very good.
I have to concur what Vladimir is saying. I think CUSA is an ideal tool for glioma, and it depends the level you are using on the CUSA. You don't need to go on 60 and 70. You go on a low-grade CUSA, and again, just touch it. As I said, let the tissue comes to the tip rather than to dig with the CUSA tip inside the tissue. But this is a valuable tool because it degrades, which the suction does not do. The CUSA has the triple function: is degrade, emulsified, and it suck. So CUSA, the suction, it won't degrade, it don't emulsified, it just suck. So I think this functionality on these tumors is very helpful with the CUSA. I agree completely with this.
But at the same
This
time,
is the invention. This is the invention. What the CUSA came for.
But as you go deeper into the tissue and you use the disintegrated function of the CUSA, you also create more edema the closer you get to the fiber tract, right? So that's why I thought when you go to the deep margin of where your fasciculus was running, that's why I would just use the suction function of the CUSA and not use the aspirator function and the disintegrating function, right? Because you have in the end, you have a pressure wave right next to the tip of your device. And I just wanted to hear his sort of strategy, how to employ this. I like the idea to come off the pedal. I've done that as well. I think that makes a lot of sense to me. glad to hear that there are different strategies and how you employ it.
When you use the specific mode, you do not need to go to the margin. The tumor comes to you, and the tip of the cusa is somewhat in some distance from the margin of the tumor, so it's really advantageous. Try that.
Good tricks.
Well,
So you agree if we go for the session 2, Imad, Ramesh?
Yeah, sure.
Ramesh, if you can go ahead, Ramesh.
Yeah, sure. Just to be clear, Pablo, we have Stefan and who else is there? I think Ek is there. Yeah,
Stefan and Ek.
that's good. So it's my great pleasure to ask for Stefan Florian. And Stefan is a great friend and so much experience, world known for his work. I know he's the most experienced in Romania and Eastern Europe. So I asked Stefan to start this presentation on gliomas.
Thank you very much. Thank you for having me here. I'm glad to see you all. Can you hear me?
Yeah.
Yes, okay. So I proposed a title that was already covered by Abinda in a first presentation, how I see the development of deep-seated malignant gliomas and what solution we propose from a research point of view. So let me start. As usual, I have no conflict of interest. My interest is to offer a chance for longer and better life to my glioma patients and to try my followers to do the same. You can find my concept in this volume of Advanced and Techniques, Standard Techniques in Neurosurgery, Chapter 9. I describe my vision on glioma surgery. I have a quite large experience on gliomas. Now it's improved. The statistic was ended at 2023. So more than 1,000 high-grade gliomas I operated, new cases up to now. So I have a concept, I have a vision. But let's start as usual, as always, with history. The first, we know that Rickman Goodley operated the first glioma in 1884, and nowadays, until nowadays, the patient outcome remains with marginal improvement since 1970s. The higher end of the current reported mean survival, it's about 60 to 18 months, which is fairly similar to the figures reported more than 20 years ago. So I don't know why my presentation is blocked a little bit. No. So Maxwell was one of the first neurosurgeons who underlined that the operation of glioblastoma multiforme, it's almost always a failure because a high percentage of glioblastoma extend into the opposite hemisphere, and he stated this in 1946. Nowadays, with the most recent tools, Wei, Lee, and Price demonstrate that there is a widespread structural impairment. It's in line with the previous studies using test resting state functional MRI, and we should view glioblastoma and treat as a systematic disease rather than a local disease. So we know maybe more, but we are not so far from those who describe. So again, the largest documented series of glioblastoma published more than 60 years ago by Ley underlined that their median survival of patients undergoing gross total resection and radiotherapy at that time was 15 months. Nowadays, the Brain and Spine Center database of the University of Texas, MD Anderson, using all the facilities they have nowadays, have a median of survival of 13.4 month. Where is the progress? I don't see, and we don't see. It was already mentioned that the one who shifted the paradigm from both neuroanatomical understanding of the brain and the localization, distribution, and progression of malignant gliomas was Yashargil. And he underlined the gliomas, doesn't matter, grade 1 to grade 4, arise in a sector of certain brain compartment. Growth, it's primarily expansive and in a retrograde direction toward the ventricle. So he also mentioned that because of this location in the different compartment, the pattern of gliomas is virtually identical. MRI studies involving the same compartments. Usually, the most of neopalaeal lesions have a pyramidal shape with the tip pointing toward the ventricle, suggesting the direction they are progressing toward. And he also mentioned that each of these compartments possesses particular vascularization concerning the arterial feeders and draining veins alike. The most important, these compartments are quite separately. The tumor being confined in this compartment usually do not transgress this compartment in normal circumstances. But even in recurrences, you can find the same localization in the same compartment, mentioned Yashargil. But he underlined the fact that the most important during the surgery is the preservation of the blood supply in adjacent, in remote areas of the tumor, taking meticulous care not to injure transit arteries or veins. This is a Transylvian approach for an insular glioma, in which you can see we coagulate all the feeders that are going to the tumor, but we are preserving the main trunk, which are supplying the adjacent regions. Again, subpial dissection in order to remove all the tumor, and in the end, you can see I use also CUSA in some parts of the tumor, and in the end, all the major vessels are preserved, and veins are arteries alike. So I avoid the rigid retraction. I use the dynamic retraction. But what are the new facts? Nowadays, it's widely accepted that glioblastoma cells may originate in the neural stem cells of the subventricular zone, which migrate and develop tumors in distant regions of the brain. The subventricular zone nets neural stem cells was demonstrated to attract so-called glioma stem cells. It was demonstrated that choroidal plexus epithelial cell contain a stem-like subpopulation which adopts a neural center in response to the composition of traumatic CSF. This is also demonstrated, and we know there is an interaction between the choroidal plexus, subventricular zone, and CSF that coordinates neurogenesis and may impact glioma behavior. And these are also facts that are in favor of our concept, that our impression is that the migration occurs not in a retrograde fashion, but from the periventricular region toward the cortex, closely following the embryological vascular print of that compartment. The role of glial stem cells, and we demonstrate, we were pioneers in research of glial stem cells researches. They have certainly a role, an important role in the development of malignant gliomas. And also this expansion of these neoplastic cells resembles the migration of glial and neuronal cells and their precursors during the brain embryogenesis from the periventricular zone, where these precursors are mostly located. According to our observation, the majority of deep-seated lesions, high-grade gliomas, meet or even invade the lateral ventricle. There is a contiguity between the innermost aspect of the tumor and the ipsilateral choroidal plexus, as you can see in these images, all three examples. And this is an intraoperative image of a transformed choroidal plexus, invade choroidal plexus by the tumor. Some of the neoplastic vessels originate from the choroid plexus, making partial resection of choroidal plexus, and this is my conception, a crucial step in surgery in achieving gross total removal and adequate hemostasis. So my understanding and in my view, the choroidal plexus demonstrated modification in both aspect and dimension in patients suffering from glioblastoma multiforme, deep-seated glioblastoma multiforme, denoting a potential activity alteration during the oncogenesis. The role and the placement of choroidal plexus in the development of high-grade gliomas, as well as in AVMs, I see a connection in these two pathologies, the intracellular communication and information transfer, as well as tumor progression, represent our research target in the hopes of developing personalized and specific multimodal treatment. And this is what we are doing. We as a neurosurgeon, we have a lot of roles in the surgery. So we decompress the tumor, and we obtain prolonged survival with a gross total removal that increase the survival rate up to 36% at 24th month in our experience. And in many of the cases, 85% of the cases, we also improve the quality of life. So we also obtain the pathological diagnosis in the most relevant part of the tumor, and we create the favorable condition for adjuvant therapy. It's also a role in education, because these tumors, having the worst prognosis, are also the field for young neurosurgeons, for training them. But I see an important role of neurosurgeon in research. We have, based on this research, we published up to now 26 ICI publication, from the clinical observation to future perspective, from glioblastoma stem cells to drug-impregnated nanoparticle for local treatment. And the last of our research domain was to realize the equipment for prolonged delivery and control of a drug, ruxolitinib, to the patient with glioblastoma. This drug, it's an inhibitor of STAT3, which is a critical oncogenic node for glioblastoma in modulating the gene expression in proliferation, apoptosis, inhibition, invasion. And our main objective was to have a tumoral bed delivery of ruxolitinib embedded in a composite fibrin gel for rapid delivery and polymer nanoparticles for a long-standing delivery in an animal model. So we see this model in the future to using this nanoparticle to inject with a supra-selective catheterization of choroidal arteries in the region of tumor development in order to stop or to block the development of this tumor. And for this project, we also create a model of glioblastoma in rat. You can see it on CT. It was developed, and also we put the nanoparticles impregnated with this drug, and we obtain certain prolonged survival in our experimental rat model. So these are the publication mainly focused on this kind of studies. And I see the role of neurosurgeon in the multidisciplinary neuro-oncological team. Firstly, neurosurgeon should have the leading position. Neurosurgeons should decide whether there is a surgical indication or not. Since the neurosurgeon should assume the clinical postoperative outcome, he or she should also decide for the timing, type of surgery, and grade of resection. Through the surgery she performed, neurosurgeon will offer the final pathological and genetic diagnosis, the prerequisite for other treatment modalities and future researches. Is the neurosurgeon who can offer not only a longer overall survival, but also a better quality of life for the patient with high-grade glioma. And finally, surgery is the first and the most important step in keep on walking. So the take-home message is, this is a very well-known painting, The Scream, that was created by Edward Munch in the same period with the first reported case of glioma resection performed by Rickman Godley. More than a century later, our patients are still screaming for our help. It's maybe time to do more. Thank you.
Thanks, Stefan. It's a brilliant talk. You outlined the issues with this condition which we are all struggling to manage, which you haven't found an answer for many years now. And especially your message about the neurosurgeon being the captain of the team, when to decide and what to decide, and at least in the initial beginning stage of this management. Something which I also noted with interest about your research about the choroid plexus, involvement of the choroid plexus in glioblastomas, as well as very similar to the AVM patients. You tend to try and, in selected cases, to resect the choroid plexus, or you don't? Is that something which you do on practical purpose?
So when I see this connection, and I always open the ventricles, and I follow the tumor until I reach the choroidal plexus, which is usually modified, globular, the globular and very hemorrhagic. So I try to resect, and I resect partially this part of the choroidal plexus. And it's the same that I do in AVM, deep-seated AVMs, because some of the feeders in the glioblastoma and also in AVMs are coming from that part of the choroidal plexus. So it's the same logic. It's the same, and you can obtain maybe a better overall survival, but certainly a good hemostasis for avoid postoperative bleeding.
Yeah, thank you. Imad, do you want to?
Any other questions or comments? Vladimir, you have done a lot of AVMs. What is your take about tracing them up to the choroid plexus? We know to the subependymal layer, but I'm not aware of the choroid plexus per se in AVM. We know they have the cone shape, and we stop at that level, but we don't trace them. Even the people have published a lot of AVMs, they haven't traced them to the choroid plexus. What do you take on?
I never do that, I've never seen really the connection between the true brain AVM and the choroid plexus. On the other hand, there always is a feeder in the periventricular gray. And this is the feeder I'm looking for actively. Okay. And I'm not sure, Stefan, that was an excellent talk, but with glioma, with high grades, once you open the ventricle and use ALA, hold the ventricle or hold the inside of the ventricle usually is red, far beyond your field of vision. That means that the tumor is spreading along the walls of the ventricle. and that's where the tumor will start growing again.
I don't see this kind of recurrences spreading in the cases I reoperate.
You never saw it? I
No.
saw it almost each high grade which enters the ventricle has extension along the walls of the ventricle if you use ALA technique. Then you really get it red.
Maybe I'm happy that I am not using.
Oh, you are not using. Then you are happy not to see it.
I don't see it.
It does not exist.
Because in Romania it's not approved yet.
I see.
Yes.
So may I be a little heretic?
I don't see it, but I operate a lot of cases with recurrences. And certainly this is a presentation of 35 for 15 minutes, but the presentation it's much longer, and I have cases in which I operate going in this way, and they are free of recurrence after 3, 4, and even 9 years.
That's an important concept with choroid plexus. Ezimat, I've never saw it, but I shall start looking for that.
That's why
Definitely.
I wanted to present, because it's something which is you cannot find in the literature, and this is our main interest in research.
Yeah. Finally, little Pablito is learning.
Well, yeah, that's why I want to stop the discussion and say all of us hi to Pablito.
Hi to Pablito.
Can I get back to?
I have one comment on Stefan's presentation. I want to ask you, perhaps I missed that point. What was the pathological evaluation of the choroid plexus you have resected? What was the pathology? Was infiltration? Was there?
Yes, it was. I don't have time, but very interesting. There is there are many fibroblasts in the choroidal plexus. We also performed electronic microscope studies in order to see if there is something. And what was really interesting was the high number of infiltration with fibroblasts, but unusual type of fibroblasts. So we started to study this aspect. What is the role of the fibroblast in the development or in the infiltration? So we are now still researching this aspect. And that's why I wanted to share with you this concept, because you are experienced neurosurgeon and anatomist, and maybe we can put our minds together in order to find maybe more.
It's always good to come with some ideas. Yes.
Yeah.
Comment?
I would like to. Stefan, that was excellent. And I fully agree with you that the neurosurgeons should stay in front of glioma, that they should deal with them. However, to be heretic, I would say that glioblastomas are not a surgical disease. The solution is elsewhere, definitely not in surgery. As far as I remember, my father was a neurosurgeon doing glioblastomas in the 50s. The routine approach at the time was lobectomy. That was true supramarginal resection. The patients were dying as early as hours, probably a little earlier. Then Kelly defined madness as doing the same thing, expecting the different result. And that is still the same. And I think that surgery is not the solution with all improvements, with all monitoring, with all QSAs, with intra-op MR and whatever. We can expect the same result in glioblastomas. All right, we shall be at the first step of the treatment. It means surgery, but then it's up to someone else to solve this issue, not we.
No, it's really, and I mentioned, surgery is only the first step in keep on walking. So surgery, and that's why we proposed maybe to find a solution to inject the choroidal plexus with some drugs, to find a solution to put some drugs on the bed, tumoral bed. So whatever, but we should operate them first to better define them, to remove the mass, to decompress the brain, to create the conditions in order to have a better result. So, but we are still, and we should be the first, not an oncologist to be the one who tells you, you should take a biopsy or something like this and send it to me to solve. No, at least in my concept, we neurosurgeon should be the leaders of the group, neuro-oncological group, and we decide when and how to operate and leave the others to treat, to complete the treatment. But also
this is something I fully agree with, because we already have left too many fields to others, you know, trauma to intensivists, pain to anesthesiologists, spine to orthopedic surgeons. So we are just being like a Black Knight who has all his limbs cut off in Monty Python, and he says, well, let's call it a draw. But shouldn't we be much more optimistic discipline without high-grade gliomas?
Get to that in a second.
But Vladimir, you say this is not surgical disease. I agree up to a point, but as Stefan mentioned, it's from the beginning you may consider this as a systemic disease, and you're never going to cure it. But that's what he thought about breast cancer in the past, and now it's becoming like a chronic disease, breast cancer, and people are surviving longer. So maybe at some stage, this may be also something which may be able to manage in the long term rather than trying to cure it with the multiple resection, multiple chemotherapy or newer drug delivery systems and all that.
Yeah,
I have to go back what Vladimir said. Perhaps everything we should take lead. In glioblastoma is a different story. And the best example, it has been for many years mentioned, that if you slice the brain far remote from the glioblastoma tumor, you will find some deposit islands of tumor cells. This is not for the surgeon to trace. And this is for somebody else that they will come with the solution. Perhaps your study of the choroid plexus as in aroma cells or the stem cells might be tackled with chemotherapy or some medication, as you said, to kill this small deposit before they become surgical.
One of the first researches we made on the glioblastoma stem cells, we put in the culture of glioblastoma stem cells along with temozolomide. And we demonstrate that in 60% of the cases, temozolomide not has no effect, but contrary, increase the neovascularization. So also we added bevacizumab because I had the idea to put something that stopped the neovascularization. And we demonstrate just before it was published, the study, the two studies on Avastin and bevacizumab, we demonstrate on the stem cells culture that there is no any effect of bevacizumab on glioblastoma stem cells. So I understand many aspects of this, but I still believe that neurosurgeon should be involved not only in operation, but also in research, in offering the solutions for the others. Thank you very much. May I ask you to allow me to go back to the department because I...
Sure.
Wonderful presentation.
Thank you.
Thank you.
Presentation.
Thank you.
Should I move to the next?
Yeah, please do, Mark. Thank you.
Yeah, the next is actually a continuity of the discussion on the glioblastoma, distinct glioblastoma, and the anatomical basis for their strategy to remove them. Ek?
Yeah. I hope I can screen share. Give me 1 second. Share. Give me 1 second to pull it up from my screen. So here we are, screen share. 1 second, here's the talk. Can you see it?
It's coming
Yes.
up, yeah.
All right. Let's do slideshow from the beginning. So thank you very much for having me, Imad and Pablo and Vladimir. I want to contribute today to this particular seminar with a focal talk on strategies for glioblastoma tumor surgery. And I want to direct this talk really to the senior resident, chief residents, and fellows when they early on in their career want to develop a practice and set up a concept of how they tackle this really difficult disease. And I want to study not just the anatomy, but how can anatomy inform us to have a good concept and a strategy, and what type of imaging we need to develop that strategy to get good outcomes for our resections. I have nothing to disclose other than the institutions that I'm working in. And this talk is a little different from what I usually do, and not unsimilar to what Abida has done earlier. We often talk about detailed anatomy and stepwise resections, but today I really want to talk about how imaging and what type of imaging can help us to formulate the strategy to optimally plan resections. And I want to briefly talk about glioblastoma types, then our brain tumor program, because I think it's really program-based, and then I give you 9 vignettes how I would exemplify this. So I think that all patients should really have brain tumor consultations from the team from the very beginning. And the reason is not just that we don't treat this patient alone. The surgeons often make the initial decisions, but patients these days are also consumers and shoppers, and their satisfaction with your services will significantly increase if you can deliver a convincing product. And part of it is that you can say, it wasn't just my idea to take this tumor out. We've discussed this between the different disciplines, and everybody thinks we should get a portion or all of this tumor out. And the patient is significantly more satisfied, even in the setting of a bad outcome, should it occur. And I think that's really important to take into consideration, because in the United States, in a fairly litigious environment, patients may come afterwards and say, you never told me the alternative to just do radiation after biopsy. And I think if we want to be the owners of this field, we need to take the patients and their personal considerations and their personal situation into our thinking pattern, because extended resection is sometimes surgically defined. You want to take out as much as possible, but a patient who is the single breadwinner, single mom, 4 kids, cannot afford a deficit, is a very different patient from a young person who has a right frontal lobe glioma and says, please take it all out. I want to live as long as possible. And one needs to take these into consideration. And therefore, in my team, everybody gets 24 hours of consultation time pre-operatively. And I bring the radiation oncologist to the bedside. I bring the neuro-oncologist to the bedside before I take the patient to the operating room. And patient satisfaction has massively improved ever since we do this. Our team is not built from anybody else. The one thing I wanted to add in is that neuropsychology should also be part of the integrative team from the beginning. Patients are very happy to know that we pay attention to their cognitive skill sets. So imaging algorithms for typical cases. For me, all patients go into portion B. Most patients that come to me are really non-incidental finding symptomatic patients, and I consider everyone surgical unless they have a contraindication for surgery. And those patients all get the same package of imaging. They get an MRI scan, T1 post-contrast MP-RAGE, T2, a CAT scan, CTA. They often get a functional MRI scan with DTIs. And then as needed, I add in MR venography, perfusion studies, angiographies, or PET scanning, because in occasional cases that will guide your strategy, what you want to do in the OR. Just like all of you know, and all of the listeners know, we need basic imaging capabilities in the hospital. Standard MRI scans, 1.5 Tesla, can give you most of the sequences you need. I would always include a GRESWI to get an idea about blood products in the lesion. And please obtain always pre and post-op DWIs to understand your iatrogenic morbidity from creating a lesion. That is honesty in reporting and will stain your future decision-making. And then we get CTAs and DSAs as needed. I more recently, in the last 10 years, have added in a lot more technology. I do 3D surface rendering to see the actual anatomy of the cortical surface, to decide which area I would like to enter and whether I can find a good sulcus to get to the lesion. All left-sided lesions get functional MRI scans, or bilingual patients get functional MRI scans. And most patients these days also get DTIs because the tractography has changed management of this disease tremendously in my hands. So I think you should develop a clear strategy pre-op, whether you want to do a biopsy only, a lesionectomy, a partial lobectomy, a full lobectomy, or whether you're even interested in doing a supramaxillary resection, which is that concept that comes from low-grade gliomas, but in a few cases can be extended into malignant gliomas if the surgery is suitable for that purpose. And then in rare cases, we need to come up with other ideas. I think consent should only happen once you have obtained all images. A lot of our university hospitals have this habit that the junior resident goes to the bedside and gets consent for you. I think that's a fundamental mistake. The first step of talking to the patient as an attending is building trust. And if you disclose honestly and openly what your plan is, you should not have any troubles in the future with postoperative outcomes. Most patients will understand that you try your best, even if there's an adverse outcome. So case number one, this looked like a fairly simple lobar right frontal glioblastoma. Came to the emergency room because of headaches. I got my usual CT scan, shows a formidable lesion, 6 centimeters in size, crossing the midline. On the CTA that I get in the ER, you already see hypovascularity medially as well as posteriorly inferiorly. There's a pedicle from the ACA feeding this tumor. There's subfalcian herniation with the ACA being affected in the midline as well. And on the first set of MRI scans on the flare, you can see that the tumor is significantly bigger than on the T1 post-contrast because it does infiltrate the corpus callosum posteriorly. It does infiltrate the head of the caudate, and there's swelling and infiltration of the anterior limb of the internal capsule. So that changes your first impression rows of this particular tumor. Not only do we want to resect the contrast-enhancing portion of the tumor, we want to know how much of this is safe to take out. So in a frontal lobotomy, we could just go to the textbooks, and if you Google, the CNS atlas that is offered from the Congress of Neurosurgery by Cohen, they just suggest a simple frontal lobotomy, lobectomy. I honestly think this is one of the worst chapters I've seen, and I want to caution you against making it too simple, because a lobotomy, or lobectomy in this case, should not just run from a precoronal entry point to the base of the anterior skull base, avoiding the corpus callosum. That's what they recommend, right? You may end up with a nice resection in terms of debulking. You may have opened the frontal horn of the ventricle, but you really have no idea whether you took the tumor out or not. And you may not be able to resect the subcallosal area and the area around the cingulum or premotor areas where you can still resect tumor that is active. So I think we can learn from the literature on epilepsy. If you look at extended frontal lobectomies for control of seizures, you think about how seizures spread. And this is relating to what Abida has done today. She introduced the deep fasciculi. Here we need to think about the superior longitudinal fasciculus that runs front to back on the upper portion of the hemisphere, and then the inferior fronto-occipital fasciculus EFOF. These are the two ones you really need to think about in addition to the uncinate and the arcuate fasciculus. What we would like to accomplish is a maximum safe resection. And if we get our DTIs adequately and we can map out the borders, you can achieve a resection that looks like this, where you use landmarks just below the bregma, go down to the corpus callosum, go anteriorly, and you end up at the level of the olfactory trigonum. You do not want to go posteriorly because the perforate substance comes posteriorly, carrying all the penetrating arteries that go into the deep portions of the basal ganglia and high real estate. But this is a much more suitable resection goal than the previously one that I showed you. That's exactly what we did in this case, right? So we did a midline opening. We were able to follow the forks, go down to the corpus callosum, make a cross-section to the entry point of the frontal horn of the lateral ventricle. And then we came in from lateral and followed the back end of the tumor. And we got a formidable resection here, knowingly leaving behind a small portion of the tumor. This is the T1 pre-contrast versus T1 post-contrast, taking out the very end here in the corpus callosum, and the tip of the head of the caudate, I think, would only add morbidity without adding benefit to the patient. So my decision was to do a maximum safe resection, and the patient was neurologically intact, able to go home day 3 after a massive surgery. Next case. Looks also simple. A lobar lesion showing up in the occipital lobe after the patient noticed anopia. The lesion on CT scan was hyperdense, showed hypervascularity again on CTA, supply from the PCA and posterior arteries. But you see on the T1 post-contrast that the lesion is buried deep in the lobe, and it does not reach the cortical surface except at the midline, but it does reach the deep portion of the ventricle. So the question is, how would you tackle this lesion? Well, here the surgical strategy should be not to do a lesionectomy, because you are functionally already disconnecting the cortex of the occipital lobe. The patient already has the deficit of hemianopia. You're not making this worse by doing a lobectomy. And coming in from the side, doing a transsulcal approach, reaching towards the atrium of the lateral ventricle, but staying posteriorly and medially. And then you go medially towards the corpus callosum and take the lobe out as is in a single piece, allows you to contain the entire lesion and gain access to the mesial temporal lobe if you have to from posteriorly. And that is the maximum safe resection in my hands. So this is the case that we did. We did a lobectomy. We stopped at the corpus callosum. You see a clean slate. The patient had a full resection of this lesion and had, besides the visual field defect, an excellent outcome and was able to continue with adjuvant care. Next case is a little bit more complex. This is again a frontal lobe glioma, but it shows up in multiple contrast-enhancing foci. You can see it's sitting above the orbital rim, but not reaching the surface towards the operculum. The lesion here was concerning for, does it invade the speech area? So obtain a pre-surgical functional MRI scan to help me delineate how far posteriorly can I go. This patient did not want to have an awake resection, so I said, okay, I'm going to do this asleep. And I took out the frontal lobe down to the corpus callosum, stayed anterior to the frontal operculum, and got a gross total resection of this contrast-enhancing lesion. All 3 spots included in the single piece of the lobe. So I wouldn't try to do a lobectomy and a lesionectomy because I may lose my landmarks. I decided to contain the entire tumor, which is one entity spreading into 3 foci in one single specimen. Now, next case. This was a young patient who showed up in the emergency room with a seizure and a T1 hypointense lesion in the lateral temporal lobe. The lesion was visible on flare, was non-contrast enhancing. The patient had 2 weeks later in my office a functional and an MRI scan where we saw a little bit of starting of contrast enhancement in this area. We then sent the patient over because of bilingual presentation to functional imaging. And just 2 weeks later, the patient had already developed 2 flare intensities. So the tumor is rapidly expanding, seems to reach up to the middle temporal gyrus, seems to reach deep. And on functional imaging, we realized most of his language performance is going to be on the left side. So it's totally safe to resect the right-sided lesion asleep, just digging out the lateral temporal lobe. We got the pre-surgical CTA showing displacement of the vessels with no involvement of the Sylvian fissure of the deep lesions. So again, we decided to follow the idea coming in from laterally, stay away from the deep-sided IFOF that needs to be preserved for functionality and visual spatial components. We decided to come in below the level of the Sylvian fissure and leave the superior temporal lobe behind, and then take out the temporal lobe inferiorly and do a full lesionectomy to stay away from the Ashland tract. And we never were close enough to the arcuate siculus anyway. This is how this looked post-operatively. We just resected the lateral portion of the temporal lobe. The deep-seated structures were never affected. On the MRI scan, you can see we've got a gross total resection of that flare abnormality without any stroke. And the patient went on to adjuvant therapy and is still alive 2.5 years later. Unfortunately, it turned out to be a glioblastoma, non-contrast enhancing. Case number 5. Again, a left temporal lobe tumor showing up in the emergency room, largely with seizures and a headache. A lot of swelling, hypodensity on CT scan, very hypervascular on the CTA, so very useful study to think about how would I tackle this lesion. Feeding vessels coming in from the ICA, possibly from the dura. So I was a little bit puzzled about this. but it was so hypervascular that I was worried about, could there be a dural AV fistula? My instinct told me get a DSA. And to my surprise, in addition to a ICA blush feeding the tumor from deep-seated ICA vessels, there was a vascular supply from the middle meningeal artery coming from the ECA. So we embolized the lateral portion of the tumor supply. I then decided when I go in and take this out, I would start laterally deconnecting the tumor from the dura first, reaching into the floor of the middle temporal fossa, and then do a wedge resection. So this is the strategy. You need to decide how far posteriorly do you want to go from the temporal tip. Fred Meyer's book from Mayo has really beautifully laid out that you can go on the left side up to 6.5 centimeters lateral temporal lobe as long as you stay away from language processing. And you need to decide how much of the medial temporal lobe structures you need to see, uncus and hippocampus. If you want to reach the hippocampus as well, you need to go more posteriorly. Otherwise, you can stay in a relatively small corridor. Your viewing angle will be inferior to the sylvian fissure, and you can disconnect the white matter tract connecting the mesial structures. So you have a lesionectomy from two cuts that connect like a wedge, and you take it out en bloc. This is how the lesion looks post-operatively. We basically disconnected the left temporal tip. We're able to take out the blood supply and achieve a cross-total resection, and the patient had no deficit afterwards. Now, this is a very similar lesion, but this is a redo operation. A patient who presented with a left temporal lobe tumor comes back a year and a half after radiation chemotherapy, now has contrast enhancement right next to the resection cavity. We did not know, is this radiation necrosis? Is this current tumor? How would we tackle this? So in this case, I added to the usual MRI, CTA, a MRP to look at, does the contrast enhancing portion correlate to hyperperfusion, reflecting that this would be likely recurrent disease versus radiation necrosis? Because if it's radiation necrosis, I could leave the patient on systemic chemotherapy and treat this with Avastin and with steroids, it would likely go away. Here, I was concerned that this was active disease because it was hyperperfused. I took the patient back and did an extended left-sided temporal lobectomy, just like the one before, came back as active disease, but we added 1 year of life expectancy without major neurological deficit. Next level complexity, case number 7. This is a case, the father of one of my colleagues who came in, who just had word finding difficulties, got a scan at a smaller outside hospital showing a lesion, contrast enhancing. This lesion is wedged between the medial temporal lobe and the lateral portion of the insula and the basal ganglia and the thalamus. Very difficult location because you know all the MCA branches are somehow involved in this or near it. So I said, I need to figure out first to what degree is his language impaired, and we mapped out functional MRI scan languages, and we got the DTIs to see that his superior longitudinal fasciculus was displaced superiorly, the motor tracts were displaced medially, the IFOF was displaced medially, and we really didn't have a concern getting anywhere near these structures. So it seemed to be more an expensile lesion than an infiltrative lesion. For those, you can think about how do you approach an insular tumor, and there are different strategies. Some of my colleagues take out the superior temporal lobe to gain access to the insula with better viewing angles. I think on the left side, you have to be fairly careful only to take the very temporal tip. But if you do so, you see the insula buried underneath. You lift up the operculum. You never want to touch the triangular portion of the operculum for language output. But then you have fairly good insight into the exposure of the insula per se. And I want to show you how we position the patient because it really makes a difference. If you take out the temporal tip, as you see here on the left-sided sketch, you can perfectly well look into the superior limbus, take out the insula, and remove the tumor without undermining or compromising the frontal operculum. And then you dissect the tumor out between the vessels of the MCA, as seen on the right side, and you should be able to reach a reasonable resection. This is the postoperative scan. You see on the CT scan, I took out the temporal tip for access corridor. My viewing angle was into the sylvian fissure from anteriorly. I left the operculum in the middle here completely untouched, but we were able to get a wedge resection and follow the tumor into the insula, never go back to posteriorly into the posterior limb of the Lehman insula, because that's where you mess up your longitudinal fasciculus, and you would disconnect functionally the left hemisphere. So my only concern for residual disease would be at the very, very end, posteriorly of that resection. And the patient had a, I would say, near total gross total resection and did well to go on to post-operative adjuvant care without a stroke, as you can see here on my DWI. Case number 8, one level of complexity. What do you do in this case? So this was a patient who came into the emergency room with headaches only, got a CAT scan, shows a dense lesion in the thalamus, bulging into the ventricle, showing contrast enhancement, showing massive hypervascularity on CTA. I was actually worried that this might be an AVM, maybe with gliosis rather than a glioblastoma. So we got a DSA showing a massive blush of tumor supplying vessels. And that was the decision for me to say, I'm not going to resect this deep-seated hypervascular lesion should this be a malignant glioma. So how would I find out? I said, okay, next level, I get an MRS. The MRS had to be a multivoxel that I get the margins of the tumor to see is there infiltrative margin that could be tumors. And yes, the MRS signature came back as this is a glioma, not just an AVM. So I now needed a tissue diagnosis. So I fused the CTA image into the pre-surgical MRI scan. I wanted to avoid hypervascularity, but get hyperdensity or hyperintensity on MRI scan. And we found a trajectory for a fixed frame stereotactic biopsy at the posterior lateral margin of the tumor to do a biopsy in the non-vascular area of the tumor, confirming that this was glioblastoma. So the patient at least had a chance to go on for focal radiation plus adjuvant chemotherapy without the risk of resection. And I thought that was a reasonable decision in this case. Finally, there are cases where we do need to realize glioblastoma is not neurosurgical disease. So this patient came into my emergency room after seizure and immediately had 3 larger lesions showing up, one superior frontal, one sitting in the head of the caudate, but infiltrating the ventricle, and one wrapped around the MCA branches. And you can see even one of them would be a formidable challenge to take out. But having 3 of them, I felt there's no benefit on the left side to chase multiple lesions. You can't do block resections. So here I opted for tissue diagnosis is needed. I decided to take out the least risky lesion, which is the left-sided superior frontal lesion, came back as glioblastoma. We offered this patient at least systemic therapy for follow-up. But this is when we as surgeons have to help our colleagues to direct further treatment options by providing appropriate tissue and molecular diagnosis for best adjuvant care. So as a summary, what did I try to convey today? For me, key steps in optimizing surgical outcome is minimizing morbidity. And sometimes you have to choose transcortical routes. And your cortical incision is really important, but not just avoiding eloquent areas. Sometimes you need to think about maybe a longer route is safer than choosing the shortest access corridor to the tumor. And thereby you can preserve tracts and neurological function significantly better, especially on the left side. If you have minimal retraction, you also have less abnormality in your postoperative outcome. So I always advocate for as little retraction as possible. I think you should consider working angles as much as possible. I spent really a lot of time in planning my cases because good outcome starts at how you position your patient and how you will be able to look into the surgical field. And that will allow you effective cross-total resections. And early exposure of vessels to take down external supply or deconnect the tumor to have a clean surgical field will allow you to make better resections because you simply see what you're doing. So I thank you for your attention. Anyone who's interested can find our write-up in this particular book chapter from Intech. And I appreciate your attention today.
Thank you, Ek, for this wonderful presentation, very compact and very comprehensive and up to the point. Many good points you have taught all of us and taught the audience how to put a strategy together to be multidisciplinary but focus in the management. Question or comment, please?
I mentioned something. Yeah, thanks, Ek. This was a brilliant talk. as Matt said, very comprehensive but very appropriate workup, and it shows the clear thinking and the strategies you employ. I think it's so important for all of us, including all the participants, to understand the planning of this. And also the examples were quite brilliant, and to say it's very appropriate. And in some cases you did angiogram, which showed some that dual fistula. Was it unrelated, or was it in the same place of your craniotomy, or was it
Same
totally,
place? Yeah.
but totally unrelated to the glioblastoma, right?
So I would say that the glioblastoma, by reaching the floor of the middle temporal fossa, somehow gained access to dural vessels and then just drew in blood supply from its release of factors.
Yeah, I mean, I think it is possible. Yeah, it is possible. I've seen it in vascular meningioma, especially hemangiopericytoma. You get big heavy dural fistulas, and also like the strategy of matching your CT angiogram with the MRI scan to look for the target to avoid a vascular problem. Thanks very much.
Any other comment?
There is a question in the chat box, Ek, if I can send it to you.
Yeah,
we have Abdusami Porsaev asking you if you use the intra-op CT or MRI perfusion during surgery to check that.
In the past, I've done intraoperative CAT scanning, but I've not done intraoperative MRI scanning at my current institution. At Mass General, we had intraoperative MRI scanning for pituitary tumors specifically. I think that actually makes more sense because you don't need to change your surgical setup and it takes minimal extra time. But I would say it is a useful tool if you have it available. It's not a must-have tool. And a lot of good anatomy will guide you through surgery without needing an intraoperative scan. In low-grade gliomas, there may be more benefit to it. So I see some institutions setting up an OR for particular pathologies, right? They have a designated sort of a glioma OR versus a meningioma OR. But I'd say in my personal practice, it's not a necessity. It would be nice to have, but I can finagle without.
I think an ultrasound helps. An ultrasound, you don't have CT, MRI, but pre-op, post-op ultrasound just to see the glioma, especially in low-grade glioma, is quite useful. That is handy. You don't have to change your workflow. You can just bring it in the operative field and use it. And when you're done with it, you're done with it.
Very good comment. I think the modern era ultrasounds that we can bring into the operating room have a resolution quality that is stunningly good and significantly better than 10 years ago. So we should all look into this because it's a much cheaper device. It's dynamic, it's real time, and it doesn't change your flow of the surgery. So you can certainly get additional information for cases where that's suitable. And the probes are relatively small. So you can get an ultrasound probe of 10 millimeter tip size, which is almost useful for all cases, except in the ventricle, I would say.
We use two modalities. We use ALA, which is good for something like film remnants. And we use intra-op MR in almost all glioblastomas. And that's good for globular remnants, which are a little hidden or something like that. And definitely we did a study some 10 years ago, and we've reached really gross total resection in more than 70% of the patients using intra-op MR. So I would consider this as the best tool. Of course, there are two indications, pituitary and gliomas, both low grades and high grades. Those are two best indications for intra-op MR. And it takes something like half an hour delay.
One important point mentioned of the use of intraoperative MRI for glioblastoma or glioma in general, we have to remember we cannot be completely reliable on anatomical landmark because there is a shift, and the only way is to discover it by the intraoperative MRI or, like Abida said, using the ultrasound. But intraoperative MRI is more for me, is more precise for this situation.
This is with intra-op MR, you are with multi-million investment.
Yeah,
And then
of course.
once you do it, you know that the remnant of the tumor is on the bottom left side of the cavity, you know, which is not enough. So what we use are like a tubes of wax, which are making like a grid within the cavity, and they help you to get the orientation again.
Yeah, nice.
That I was ready to ask you, Vlad. What do you use in the intra-op MRI as the spots, and this is wax? So you mark it with wax, bone wax.
Yes. Like small, you know, pieces of wax, and you put them. Usually there are 4, and you make a grid. 90 degrees.
Yeah.
Very nice.
Any other comments? I'd like to give message, if you allow me, Pablo. The message is not for the people attending, but for the members who are not attending. That academy has been successful by its webinar, by on-site courses, and the book we have achieved all together. But the most beautiful part of the beautiful part is that discussion we have at the end of each lecture and session. And that's why I like other members to attend. They just not come to listen to their lecture. They have to come to listen to others and interact and give input, question whether it's their ignorance about it or they share their experience. I have to comment Giovanni. Giovanni, he is the most experienced senior among us. He doesn't miss one attention of this one and contribute. And that's what we want to have. And that's why people, 1,000 or more than this, attending our presentation. So the message for members listening to us, please come even you are not on the presentation list. And we want you to be among the picture together in this situation. The other things I'd like to welcome one new candidate, and you all know of him, is Fadi Sharber. He is a very senior guy. He has been supportive to our IANA, and I have invited him on your behalf, and he accepted the invitation. I hope he will be an add-on merits to this board of directors. I leave the venue for you, Pablo. I'd like to commend you. You have been very apprehensive, very attentive, and you have made a marvelous job, and you continue to do that. Pablo, is this floor for you? And Vladimir, if you want to say any words, please go ahead.
No, you said it well.
I like to see all these people around us.
It's written on the side because you told those to attend who are here, you know. This should be said to those who are not here. But
That's
hopefully by some spread, they will listen to that. No, I have nothing to add. This was a beautiful webinar, and really the discussions, as you said at the end of the lectures, is probably the most important part of our endeavor. Pablo, up to you.
Nothing to say. Thank you, everyone. And as Imad has said, this is the book of the year. You can see the editors. These are the leaders of the academy, of this fantastic group of people. It's now almost 5 years since we started the online events with the strength of Imad and Vlad. And I'm super honored and happy that we had 500 people registered for this glioma webinar, which Vladimir always says that this is the yogurt that you have to be aware of, but he really likes this. I know now. I know that.
Did I tell you how many people are watching us on YouTube? By now there is 140,000 accesses to the library Pablo did. There is 3,500 subscribers to our webinars. So it's an incredible number. Ultimately, each webinar is viewed by something like 5,000 to 6,000 attendees. So this is marvelous. That's something which really cannot be repeated. So let's keep it and let's work on it in future.
By all
I'm
means.
sure Pablo has some plan, I know, about the on-site courses, and I think you will furnish all of us with the future plan. I leave it for you for when you have it ready. But we have several attempts for this year, and I hope that will be an add-on for our activities.
I will let you know. I will send you very soon a draft of potential venues and organizations that are contacting us to cooperate with them. So next Tuesday, 25th of March, we'll have the second part of this intraaxial anatomy, function, and oncology, let's say, webinar, and it will be more focused on the functional side and the brainstem.
Before you leave, Pablo, who is the master of taking picture of all the group together?
I will, if you allow me.
Yeah.
Giovanni, are you ready for the picture?
Giovanni is not shown very well.
We only see the top of his head, which is the important part of his body, actually.
So, let's say...
All right. Papito.
Perfect. Thank you, guys.
Thank you, everyone.
Have a nice day.
We stay in touch. Bye-bye.
Sure.
Avi, thank you.
Bye.
Bye, Ek.
Bye-bye.
Bye-bye, Vlad.
Bye.
Bye.
Ramesh, thank you.
Bye, Pablito. Bye. Ciao,
Bye,
ciao.
Pablito.
Bye-bye. Adios.
Bye.
Adios.
Hey.
Di adios.
Can show him the Predator.
Is it with you, Predator?
Yeah, Berte, pozor.
Mira, mira, mira.
Ke mně, ke mně. Ke mně, pojď ke mně. Pablito.
Oh, mira.
Oh, wow. It's a cute one. Beautiful.
All right. Gentlemen.
Bye-bye.
Enjoy.
Enjoy the rest of the day. Bye-bye, Ramesh.
Bye-bye.
Bye-bye.
Bye.